Good evening, everyone, and thank you to Dr. Rakesh Sahai, sir, for the kind introduction. And thank you to Dr. Sanjay Kalra, sir, for this opportunity, and Dr. A.K. Das, sir, for wonderful, initiation of the program. So today I'm going to speak on a very, very important topic, that is obstructive sleep apnea. But we'll not be talking about obstructive sleep apnea per se. We'll be talking about its relation with diabetes and metabolic health and cardiovascular health in general. So, Thomas Dekker said that sleep is a golden chain that ties health and our bodies together. And it's a very important aspect of our life, just like eating food is concerned, or just like breathing, or just like, having a glass of water. Sleep is as important for our life as anything else. Now, why, as you can see from these recent winnings from Nobel Prize winners in physiology, two of them in 2017 and 2019, both of them went to this field of obstructive sleep apnea and sleep in particular. The 2017 Nobel Prize winners talked about circadian rhythm, which is very strong correlation with endocrinology. And then 2019, they talked about hypoxia sensing mechanisms, which again has correlation with obstructive sleep apnea. So I think this is a topic which is extremely in limelight. Now we have a lot of wearable devices as well, which talk about sleep, and sleep has become an important area of research as well as area of study for a lot of scholars. So basically, there are 90 different types of sleep disorder. If you take the ICD-10 definition of sleep disorders, there'll be many of them. Some of the common ones which we all come across are insomnia, sleep-related breathing disorders, of which OSA is one of them, sleep-related movement disorders, circadian rhythm-related disorders, and so on and so forth. So there are many of these disorders. But in practice, we generally come across insomnia and sleep-related breathing disorders, which come to endocrinologists and physicians often in our practice. So what exactly is obstructive sleep apnea? Now, there is, of course, a formal definition, but then there is an objective definition of obstructive sleep apnea. So obstructive sleep apnea is basically daytime somnolence with at least 5 episodes of obstructive breathing during sleep, which is defined by apnea lasting for more than 10 seconds, or hypopnea, which is more than 50% reduction of airflow lasting for more than 10 seconds. Now, you will often wonder where this apnea and hypopnea comes from. This comes from polysomnography, which we'll be discussing in a few slides later. So this is the objective definition of obstructive sleep apnea. Now, 3 very important things about OSA, and which you should all be aware. And I think, if you listen to this topic, you'll realize how common obstructive sleep apnea is. In fact, it is more common then you think about. Perhaps you might find people in your family who might be having obstructive sleep apnea and they don't know about it. So a very important pillar of OSA, where you should consider OSA, is the presence of daytime somnolence. That is, somebody who is, feeling sleepy during a lecture, or perhaps, sleeps in the car, sleeps while driving. These are all signs of, sleeps while, the break between seeing patients, these are all signs of daytime somnolence. Snoring is an important aspect, and then you have witnessed apnea during sleep by the partner or by the family member. These are a classical triad of an obstructive sleep apnea. Now, unfortunately, obstructive sleep apnea is much more common in our society than we think. And in fact, 15 to 30% of adult males and 5 to 15% of females have OSA. So it's very, very common. Of course, the degree of OSA may differ amongst these individuals, but it's much more common than we think about. And unfortunately, we are not diagnosing it as common as we should be doing. So what are the clinical features of OSA, and where should you suspect an obstructive sleep apnea? So like I said, the most important and cornerstone of obstructive sleep apnea is daytime sleepiness, right? So a lot of these patients have, you have patients falling asleep during daytime, spontaneously falling asleep or feeling sleepy during daytime, in a meeting, or perhaps while driving, like I said, perhaps during a lecture for a student, perhaps while listening to my lecture. Well, these are all signs of obstructive sleep apnea. Then there is non-restorative sleep. They'll have loud snoring. They'll have witnessed apnea, which is seen by the bed partner. They'll often get up with choking or gasping episodes during nighttime. They'll have restlessness during nighttime. There is also insomnia, and I'll discuss this point as well. In the daytime, they'll have lack of concentration, they'll have cognitive deficiencies, they'll have changes in moods, morning headaches, very common. This is very, very important. They'll often have very strange dreams. they'll often get up at night to for urination and so on and so forth. And tell me, I think when I look at this, I think some of these symptoms I already have myself. Or if you talk about your own life, perhaps you might be, or someone in your family could be having these symptoms, right? These are very common symptoms of obstructive sleep apnea. But can insomnia be a sign of obstructive sleep apnea? And a lot of patients complain of us. When I see my outpatient department, a lot of patients who complain of insomnia, right? So can insomnia be a sign of OSA? Yes, it is. So about 1/3 of patients, especially females with obstructive sleep apnea, often complain of insomnia rather than daytime sleepiness. So insomnia can be also a symptom of OSA. And this is what is known as sleep maintenance insomnia. So what happens is sometimes these people, they tend to take a nap during daytime, perhaps take a longer nap during daytime because they feel sleepy during day, and then they have difficulty falling asleep during nighttime. So that kind of symptoms can, insomnia also can be a symptom of an OSA. And again, you should keep your eyes and ears open, perhaps trying to diagnose this. Of course, what are the factors which are well-defined risk factors for OSA? Sleep, disorders in general per se, old age, male gender, as we saw, obesity. In fact, testosterone has a link with OSA, and a lot of endocrinologists will tell you that testosterone replacement in hypogonadal men can increase or worsen OSA. Obesity, very definitely related with OSA, and Dr. Nitin Kapoor talked about this in his talk as well. One of the S of the obesity or pre-diabetes. Craniofacial abnormalities, upper airway abnormalities, if you have a large goiter, for example, that could be a cause of OSA, or that could potentially worsen OSA. And then, of course, you have other potential risk factors like family history, smoking, nasal congestion, and so on and so forth. In a clinical examination, this is what you should be looking for. Obviously, an obese patient, you should suspect an OSA. They have a narrow and crowded airway, large neck circumference, and this is very important. In fact, studies have shown that neck circumference more than 17 inch has strong correlation with the presence or absence of OSA. And if you have craniofacial abnormalities or facial, the jaw, the mandible has been pushed back, as in retrogradia, in such a situation, again you should think of the patient might be having an OSA. Then, of course, OSA has impact on, is impacted by other disorders. For example, type 2 diabetes. Remember, diabetes has a bidirectional link with OSA. So OSA can lead to diabetes, and diabetes can worsen OSA. Hypothyroidism is another common endocrine disorder that we see, which has linked with OSA. Especially, again, a lot of these patients may have a goiter as well, which can impact this. PCOS, acromegaly, very important. Pregnancy can worsen OSA. End-stage renal disease, heart failure patients. Again, there's heart failure has a very strong correlation with OSA. Obesity, hypoventilation syndrome. So some of these obese patients have combination of OSA with obesity hypoventilation. Presence of a chronic lung disease can worsen it. And again, stroke. So stroke also has a bidirectional link with OSA, and stroke can worsen OSA, and OSA can increase the risk of stroke. So this is again something which is very important. So how do you diagnose an obstructive sleep apnea? Well, you do it with a questionnaire. The initial, of course, screening is done by a questionnaire. There are many questionnaires. The one which is standard is Epworth Sleepiness Scale, which is a standard questionnaire. This is easily available online. You can download it as a PDF and administer to your patients. There are several points in this, and the ESS score, which if the value is more than 9. That is again suggestive of the patient having obstructive sleep apnea, and then this patient should be further investigated by doing a polysomnography. There are many other questionnaires. The two other ones, which are Berlin questionnaire and the Stop Bang questionnaire. Now, the one I use in my practice is a Stop Bang questionnaire because it is easy to administer, quick, and of course, there is good evidence to suggest its use. So this is the Stop Bang questionnaire. So these are simple points. Do you snore loudly, louder than talking? These are yes or no questions. Of course, snoring cannot be judged by the patient himself. So you'll have to, or herself, the partner would also be required to give evidence for this. Do you feel tired or fatigued during daytime? Again, very important. Has anyone observed you stop breathing during night? So these are, if you see, the first three are the three pillars of OSA diagnosis. Do you have high blood pressure? Again, hypertension is associated with OSA. So this is important. In fact, resistant hypertension, one of the causes you should think of is OSA. So again, very important. And then, of course, you have, this is Stop, and then you have Bang, BMI more than 35, age more than 50 years, neck circumference more than 40 centimeters or 17 inches, and male gender. These are all features which are risk factors for OSA. And yes or no questions, simple to administer. And if the score is more than 1 for each of this response, then you total the score, and then if it is 0 to 2, it is low risk, 3 to 4 intermediate, and more than 5, it makes it a high risk patient for OSA. So anyways, if you see a 50-year-old male with a 50-year-old male with BMI more than 35 automatically falls in the intermediate risk, whether the other things are there or not. So, you should be really keeping, again, like I said, your eyes and ears and, open for trying to make a diagnosis of OSA. Then, of course, the gold standard of diagnosis actually is a polysomnography. This is, there are two types of polysomnography. One is full night study, and there is what is known as a split night study. I'll not go into details of these. You can perhaps, there are doctors now who practice dedicated sleep medicine. Certain pulmonologists, certain neurologists who have started taking up the task of doing sleep medicine. And you have home sleep apnea testing, which is now available, and a lot of companies also offer this as a part of patient awareness or kind of programs as well. So you have home sleep apnea and polysomnography, or formal polysomnography, both of which can be done. Generally, of course, experts suggest doing a polysomnography as a standard of care, but in certain patients who may not be willing for that, you might do a home sleep apnea testing as well. So the gold standard for diagnosis is basically polysomnography. So ultimately, the diagnosis has to come from this, and home sleep apnea testing can be just perhaps a conduit to doing a formal polysomnography. Again, it's very important to understand, even from as a physician, that again, unexplained pulmonary hypertension, or in fact resistant hypertension, resistant systemic hypertension, both of which can be because of OSA, and again, that should be something which is important. So what is the diagnostic criteria for OSA? We already discussed this in the very first slide. But if a patient is completely asymptomatic, let's say you're just done as a part of routine testing a polysomnography, or the patient just out of curiosity you did this, and there are more than 15 or more episodes of apnea, hypopnea, or what is known as RERA, respiratory related arousal per hour, then it is suggestive of that is diagnostic of OSA. And if the patient is already symptomatic, like we discussed, patient having daytime somnolence and so on and so forth, 5 or more episodes per hour is suggestive of OSA. Then, of course, there are indices. You have something known as apnea hypopnea index. So this is basically apnea plus hypopnea in total. So total duration divided by the total duration of sleep in hours, and this will give you an hourly estimate of this value. And then you have respiratory disturbance index, which includes apnea, hypopnea, and RERA. Total duration again, and divide this by total duration of sleep, and this will give you the hourly estimate. So these are just basically indices which help you to have easy communication with your with other specialties, and perhaps considering clinical trials and further studies. So in terms of severity, again, AHI, RDI can be used to classify severity. So mild is basically when values are more than 5 to 15. Remember, less than 5 rules out OSA. 5 to 14 will be considered mild, 15 to 30 will be considered moderate, and those with more than 30 would be considered to have severe OSA. So what are the consequences of OSA, right? Why OSA is so important? Most important perhaps, which extremely underestimated and under-recognized and perhaps underreported, is increased risk of motor vehicle accidents. This is very, very important. And I think, this is a common public health problem. It's not just a problem for doctors. It's a problem for the society. So this is something we should be looking at and seeing this as an important part. In fact, I remember I had this patient who complained exactly about OSA, and the patient had uncontrolled diabetes. But I think I said, this is an important priority, because perhaps controlling your diabetes is not going to kill you, poorly controlled diabetes is not going to kill you the next day. But if you have a motor vehicle accident, perhaps while just driving back home from this hospital, it could be fatal, right? So you should be it is very, very important, and you should of course be looking at if the patient has history of falling asleep while driving during daytime. Extremely big red alert for considering OSA. That could lead to neuropsychiatric dysfunction, patient feeling depressed, anxious. There is increased risk of cardiovascular disease. There is pulmonary hypertension and right heart failure, which we already discussed. And then there is risk of metabolic syndrome and type 2 diabetes, which we'll discuss in the next few slides, and risk of NASH and FLD. So all these things are important consequences of OSA, and they should all be explored. So let's talk about diabetes and OSA. So what is the link? So 40% of patients with OSA go on to develop type 2 diabetes, and 23% of patients with type 2 diabetes have OSA. So there's a bi-directional link between these two, and 58% of patients with in diabetes have some form of sleep disordered breathing. So OSA is one form of sleep disordered breathing. There are other forms like central sleep apnea and so on. So almost 50% of your diabetic patients have some form of sleep disordered breathing, which also needs to be corrected if you want to achieve your glycemic happiness or glycemic hygiene, which Dr. Arundhati just talked about in the previous talk. So there are clinical studies which have shown a close relation. There is something known as a Wisconsin sleep study, and there is sleep health heart study, both of which have shown this data and this relationship between diabetes mellitus and OSA, this bidirectional link between these two. Again, is sleep duration important, right? So a lot of patients often tell us, and I remember, when I was working in Delhi, we used to have a lot of patients who came from, Gurgaon or Noida, where there is, all these call centers which are startup young people who developed new onset of type 2 diabetes, and they were sleep deprived very clearly. Shift workers, doctors, a lot of doctors who work in emergency care tend to develop diabetes very commonly. So sleep duration and sleep deprivation definitely has link with diabetes, and both short duration of sleep, so there's duration sleep less than 6 hours, or even long duration of sleep, more than 9 hours of sleep, is associated with increased risk of diabetes. And this link has been done by, has come from EPIC study. And there are, of course, many follow-up studies also which have shown similar correlation. So clearly, both sleep deprivation and excessive sleeping, both of which have link with risk of developing type 2 diabetes. So again, this is a study which is done by Gottlieb, and clearly again they have shown they've broken down the duration of sleep, and again less than 5 hours of sleep is associated with almost twice the risk of developing diabetes. And this is again, if you see the risk ratio here, the odds ratio here, it's clearly significant. Again, more than 9 hours also, it is significant. So less than equal to 5 hours of sleep, or more than equal to 9 hours of sleep, is associated with increased risk of diabetes mellitus. Now, what about OSA and the diabetes risk? Now, what is very interesting and very important, and a lot of this comes from work done by Dr. Naresh Punjabi, who is, I think, an authority in the field of sleep in relation with diabetes. And I think, you can read some of his papers. They're excellent on this topic, and some of his talks also are brilliant on this. So what Dr. Punjabi tends to say is that there are two aspects of this. One is that sleep apnea leads to sleep fragmentation, which activates the sympathetic system, and the HP axis gets disturbed, and there is a systemic inflammation which happens. All of these ultimately lead to insulin resistance. But remember, we all know that diabetes is not a disease of insulin resistance alone. It is a disease of imbalance between insulin resistance and beta cell function. And this intermittent hypoxia that happens in patients with diabetes, that contributes to beta cell dysfunction. In fact, there are studies done in animal models that any form of hypoxia produces beta cell dysfunction. Nowadays, and I'll tell you the best example of this is COVID-19. You had patients with COVID-19 who develop hypoxia, and these patients go on to develop beta cell dysfunction and severe hyperglycemia. So there is a link between hypoxia and beta cell dysfunction, and there's of course also a link between the sleep apnea causing sleep fragmentation, which leads to insulin resistance. And this combination of these two ultimately lead to type 2 diabetes. So this is a very important correlation, and this is something we should understand while dealing with these patients. Of course, there's also a link between OSA and cardiovascular disease. So OSA clearly leads to hypertension. It also leads to hypertension, which is often you'll have resistant hypertension. The patient will require multiple medications for treatment. Hence again you should look at this in a very close way. When you have a patient with resistant hypertension, obese patient, perhaps OSA should be ruled out. And of course, you have increased cardiovascular mortality also due to arrhythmia. Now, there's a very interesting thing I'll tell you. There is something known as a mammalian diving reflex. These are some of these, you have this neonatal or infantile reflexes which are there in all human beings at birth. Well, one of the reflex which we have inherited from our ancient ancestors is a mammalian diving reflex. So, when a mammal dives, the body adapts to this diving by reducing the heart rate or producing bradycardia. And this is known as a mammalian diving reflex. So whenever, you have intermittent episodes of hypoxia, the body perceives these episodes as diving, and the body produces bradycardia, and this bradycardia can sometimes trigger arrhythmias. So this is very important, I think, and this is important cause of, you all know this death in bed syndrome. Well, OSA could be also a contributory factor to death in bed, apart from, of course, another very important aspect in diabetes is hypoglycemia. So this, both of which can potentially contribute to a patient sleeping alive and dying in his sleep, right? Which is a very, very, perhaps not a bad way of dying, but, perhaps a very, scary thought for all of us. So, of course, I'll not go into details of the link between OSA and cardiovascular disease. This could be a topic in itself. But ultimately, what we need to understand is that we know that OSA leads to insulin resistance. We also need know that hypoxia or intermittent hypoxia is a situation which produces low-grade inflammation, which can have impact on multiple organs of the body, including the liver, the cardiovascular system, and the pancreas, and the resistant aspects. So, now comes the question which we all want to probably ask is that does correction of OSA improve the glycemic control in the patient? Now, this is the other way of thinking, right? So we know that OSA leads to diabetes, but does treatment of OSA improve the diabetes? The answer is perhaps no. It's not a clear answer. At this point of time, the studies have shown that the impact of OSA treatment on glycemic control has revealed mixed results. There are certain large studies which have shown result to be negative, whereas certain smaller studies have shown the results to be very, very positive. So I think there is a mixed result, and I think perhaps a good long clinical trial would give us a more clear aspect to this. Unfortunately, there's also a problem that the treatment for OSA right now is still primitive, and there are still the advancements happening in terms of treatment. So hence, we do not know the full aspect of treating OSA, and hence perhaps we do not know the full aspect of the development which can happen in this field. However, of course, there is an impact on cardiovascular disease and reduction in mortality, which is very, very clearly established. So patients with OSA who are treated, in such patients, the risk of cardiovascular disease is definitely reduced. So from a cardiovascular point of view, it is definitely helpful, but perhaps treatment may not be completely helpful in terms of glycemic control. But of course, there are some studies which have shown some benefit, but in a long term, perhaps we don't have good result to show there. So how do you manage OSA per se? So there are, 4 major aspects. Of course, like anything else, lifestyle measure comes first. You have oral appliances, you have positive airway therapy or positive airway pressure therapy, and you have surgery. So these are various aspects of treatment. Lifestyle measure includes weight loss, sleep hygiene, and so on and so forth. But of course, position is also important. Some patients have a positional OSA, which is confirmed by polysomnography. So such patients, especially if they lie on their back, they have more episodes of OSA. When they lie on a sideways, the OSA often goes away. So I think if this has been determined by polysomnography, I think perhaps again patient could be advised to lie on the sides instead of lying on their back. And again, this could be helpful in some of these patients. Of course, positive airway therapy is the standard of care in terms of treatment, and it is recommended in patients with severe OSA, that is patients having AHI or RDI more than 30. For mild to moderate cases, you can use an oral appliance versus CPAP, but in patients with severe OSA, definitely a CPAP therapy or a positive airway pressure therapy is recommended. Now there are various modes of giving positive airway therapy. You have continuous CPAP, you have bi-level positive airway therapy, you have auto titrating, and you have adapting seroventilation therapies. Again, not going into details of these, perhaps you can discuss with your sleep specialist on this. But these are various treatment options which are potentially available for your patients in terms of positive airway pressure. Now these have become very popular. These have become even cheaper as well. So more and more people are opting for this form of therapy at their homes. Then of course there are oral appliances. There is something known as a mandibular advancement splint, and then there is a tongue restraining device, and these tend to kind of pull the tongue out to have more retrolingual space to allow for better airway. And these are some, again, this is a mandibular splint, advancement splint. This has to be kind of positioned by orthodontist. And so it's a little bit painful and difficult procedure, but it's been found to be very effective. It increases the anterior, posterior, and lateral retrolingual space, and retropalatal enlargement also is seen. So it kind of improves the upper airway. When do you perform a surgery? Well, surgery, it's still clearly it's not been established in terms of benefit, but those patients having some other upper airway obstructing features, like for example those having tonsillar hypertrophy or adenoid hypertrophy or craniofacial abnormalities, all these patients should definitely be considered for surgery, because all these correcting these abnormalities can definitely improve their sleep in a long run. Then of course there is a new therapy which is coming in, which is known as hypoglossal nerve stimulation. It's again a surgical approach which is tried in selected patients, and there is an implanted neurostimulator that stimulates the hypoglossal nerve, which prevents the collapse of the airway during sleep time, and hence keeps the airway patent during sleep. So this has been a therapy which is still it's been used in certain places, but it's still nascent and not been tried in a large population. So only selected patients may undergo these kind of procedures. And then there are pharmacological therapies which are again not very well been established. So some medications like theophylline or decipramine, etc., have been tried, but results have not been very encouraging for patients in general. But a cannabinoid agent, which is known as dronabinol, has been tested. It's showing promise, but at this point of time, the American Sleep Medicine Society is not recommending this drug. We still need more data on this, but then this is showing some good promising results, and perhaps maybe in future we might have this as a medical therapeutic option as well. Some patients continue to have, despite having a CPAP, continue to complain about daytime sleepiness. See, daytime sleepiness is very important. All of us do some kind of positive work during daytime. Whether we are seeing patients, performing surgeries, attending meetings, writing up code, whatever, right? We all need to do some productive work during daytime, maybe driving. All these things are important, right? So modafinil is one drug which is now available in India very easily, and this could be a useful drug in certain these patients who tend to have residual daytime somnolence. So with this, I'd like to conclude and give you some take-home message. But before I go ahead, just one very important take-home message is that if you want to test somebody for obstructive sleep apnea, I think the first person you should test is your driver, because that could be very, very dangerous. But jokes apart, something very important, that daytime somnolence and insomnia are important telltale signs of OSA. So the classical triad which I talked about, and they are not uncommon in diabetic individuals. So you should keep your eyes, ears, nose open for them. And of course, sleep deprivation contributes to insulin resistance, while hypoxia contributes to beta cell dysfunction. This has importance beyond OSA, so please keep this in mind. And a combination of these is seen in OSA, which increases the risk of diabetes as well as cardiovascular risk. And positive airway pressure is an important form of therapy for OSA. However, its impact on glycemic control is not known. However, it does improve cardiovascular outcome. Right. So this is our just quickly. This is our app on notes in endocrinology. So you can download this free of charge. And thank you for a patient listening.